Beautiful.
This will be the first of a few series of webinars that I hope to host. And the reason they came about is because we get a lot of questions, and as much as we'd love to answer everyone individually before a family comes to the office, sometimes we don't have that ability as a team. And I think these are questions that the parents will be able to have answered, and then just a resource for them and for our community resources. So this one we're going to focus on really the beginning information on what is a tongue tie and what I would like every parent to know that's having infant feeding struggles. And then we already went through that one. So thanks for joining. Again, if you have any questions, feel free to drop them in that chat box. I'll follow up with as many as I can at the end. And then for those complex questions, there's a few ways to reach out and then we'll be able to answer them. But mostly, there are no silly questions because as a provider, you're answering questions for your patients. And as a parent, it is very personal information. So these are parents trying to get clarity. So ask whatever you need. Just maybe don't say your baby's name or all that HIPAA important information that I know y'all know so well. All right. So I'm Dr. Casey Collada. I'm the founder of Latched Beginnings, and I'm really proud because in October, we're celebrating our 5-year anniversary being open in Austin. I specialize in oral tie treatment, and we specifically treat infants. And the reason we treat infants is to help with infant feeding. But with my background in dentistry and myofunctional, I know that by treating infants for oral ties when they're presenting early on with feeding issues, we're actually helping them long term with oral function and airway development. We always like to say, and it's so true, that breathing comes before feeding, and feeding comes before speech, and speech comes before all these other things that happen in the body. So it's a cycle, and by starting early, we're going to help that child overall. I have over a decade of experience supporting families here in Austin, and my most important adjective that I like to share, and for those who know me already, is that I'm a mom to two fantastic daughters. Isla, who is 2, and Arlo, who is now 6 and starting first grade soon, which I can't believe. What we're going to cover today in this quick webinar is just like we spoke about, what a tongue tie is and how it might present a little bit different than other feeding issues. We'll go over those most common signs and symptoms in babies. We'll touch on a little bit of why ties might go unnoticed or undiagnosed before, and then we'll get into what an untreated tongue tie might affect later in life, and then also if these are starting to alert you to maybe not red flags, but yellow flags for both your patients or for your kiddos, what those next steps might be if you suspect an oral tie is present. So one of the things that I really stress when I talk to parents is that in order to understand a tie, we need to really be good at understanding normal anatomy and that normal anatomy exists, and then teasing that away to see if it's abnormal. And what I mean by that is there is a frenulum in everybody, and we need to understand what a normal frenulum is. So the frenulum is that vertical band in your mouth, and it's a set of connective tissues. One of the things that parents are shocked to find out when they come to the office is that you have 5 of them, and sometimes 7. It depends on the patient, but you always will have a frenulum underneath your top lip, underneath your bottom lip, under your tongue, and in your cheeks. So sometimes you'll have noticeable ones just on the top cheeks. Sometimes you'll have them on the bottom as well. So that's where we get 5 to 7. Frenulum are normal. Everybody should have them. It's only a tie when that frenulum is so strict or so restricted that it can't move correctly. So these frenulum, for those that are science-minded, are type 1 collagen. And collagen is made throughout your body, but collagen that's type 1 is more dense. It's more related to what's in bones and tendons. Type 3 collagen is what you'll see in a muscle. So I often get families that ask me, does a frenulum stretch out? And the answer is no. The frenulum itself will not stretch out, but the muscles around that the infant has learned to compensate can. So that's why having a provider that we'll talk about later on, it's so important to have collaborative therapies because an infant might need more than one thing. The other thing I like to tell parents is that oral anatomy, frenulums, tongues, lip, they start forming when that mother is 2 months pregnant. So even when we see an infant that's a month old or 3 months old, yes, they are brand new to the world, but they have learned to use their swallowing reflex, to use their tongue since that mark, 2 months in pregnancy. So they might be 2 months old, but they've learned that swallowing complex for a year, and it's going to take some time for them to learn the correct swallow and the correct muscle coordination and strength. So when we talk about ties, this is where we're talking about a restricted frenulum. And a tongue tie specifically, that's when the frenulum underneath the tongue is restricted. And there's 2 ways that it can be restricted. And this is another reason there's a lot of confusion. The first way is the most obvious way, where the frenulum is really far forward on the tongue. And these are what are called anterior tongue ties. And these are ones that you don't have to have even seen an infant before to know that something's wrong, that this infant can't move their tongue at all or very limited. But the other way that a tongue can be tied is that when we talk about a mid-tongue restriction, or what is more commonly called a posterior tongue restriction, and that's when the frenulum is not at the tip, but it's a little bit farther back. And the problem there is that the frenulum can be really short. So even though it looks like it's in the general right spot, it's not able to move. It's not able to elevate to the palate because that frenulum is just too short. I like to tell parents this is very similar to if you have a rope and the rope is just too short. It's the right rope, it's the right material, but in function, it's not going to help you. And these tongue ties can impact big things. So another another question I get a lot is, can tongue ties only affect infants that are breastfeeding? And the answer is a resounding no, because an infant that's tied is going to have an incorrect latch at breast or at bottle. They're going to have poor milk transfer, so efficiency and eating at breast or at bottle. And regardless if that infant is fed at breast or at bottle, if they're not able to suckle correctly, that's when we get into this diagram of having poor oral motor development, where they're going to start engaging the muscles that they shouldn't. And that's usually those big TMJ muscles, right? The masseter, the neck muscles, they start to get stiff. And it's because infants are so smart. They will do what they need to with what they have. And if they can't move their tongue to be able to eat, they're going to start employing the big muscles to do that. And that's when we start getting into that oral motor development, but also breathing and airway function and sleep as they get older. So, like we spoke about, there are multiple places that frenulum exist. And the lip ties are one, and the buccal ties are ones that I find a lot of providers aren't looking for.
Dr. Kulata.
Yeah, yeah. So the lip ties, and most importantly, the top lip is going to be important for our feeding infants, but also buccal ties can have a big impact. Lip ties and buccal ties, especially if you can't move that lip, the infant might look like it starts with this really top lip that's flanged out and the bottom lip that flanged out, and it looks like a great latch. And then the parent will say, oh, but I looked away and the top lip tucked in, and that latch that started off so nice is no so chompy and shallow. And so a lip tie in itself can be an issue. I have treated several infants. They didn't have a tongue tie. They only had a lip tie. I've treated way more that have had both. And, some every now and then will have all of them that need to be released in terms of the top lip and the buccals and the tongue. So don't underestimate how important a top lip tie can be with oral mechanics. And these are common signs of ties in babies. You'll receive our common sign checklist for anyone who signed up for this link. So don't feel like you have to write notes on this. This will all be sent back. But the most common signs that we have for infants that will call are the poor shallow latch, pain for feeding, frequent popping and on and off because they can't maintain a really great latch. We hear clicking sounds a lot, gassiness and reflux. Inadequate weight gain is one. But I'm always hesitant to talk to that about parents because as much as I'll see infants that are not gaining weight that have ties, I probably see equally families who have infants that have ties that are gaining weight. But it's because the family is putting so much work into feeding their infant to get them to gain that weight. So, yes, they look great on the scale and on their growth chart. But if you ask the parents, how are you doing that? They'll tell you, well, we feed them 20 times a day, or we triple feed, and that we feed them at breast, mom pumps, and then they feed the infant a bottle that's supplementing after every feed. And for most families, and as a mom myself, that's really not a sustainable model to feed your infant. Um, the other question I get is, do oral ties always cause pain for the mom that's
I'm gonna
feeding
vote
them?
for you.
Yeah, the answer is no, it doesn't always cause pain. Um, it can, but it also can't, especially if this mom has breastfed before, um, or if there's other factors at play. So this checklist again, we'll send it. And if you have any questions, just send them on the chat and I'll take a look at them at the end. So this is a question, why are tongue ties so often missed? That I have to be honest, I don't love answering, but it's important for families to know. Tongue ties are really often undiagnosed and also in certain communities because they don't have a provider that's trained in oral assessments. So just like we talked about how there could be anterior ties that are visible, but mid-tongue or posterior restrictions that aren't quite as visible, and we're looking more at function, we need to look as providers at the visual cues of a tie because we have to do a clinical evaluation. But we most importantly need to look at how the tongue and the oral development is happening and functioning. And then three, we need to pair that with the symptoms that the family is having. So sometimes we'll get photos of infants and patients will send them, does my baby have a tie? And I always tell them, I can't tell if your baby has a tie that needs any treatment based off one photo. We really are going to have to connect these three things together to see if it makes sense for us to have an actionable item or not. And if your provider is not trained in those nuances, these are the questions that will get glossed over. And it's not because they're trying to be a bad provider. I truly think that all of these providers that care for infants really want them to do well. It's because they just don't know the answer. We often have tongue ties that are undiagnosed because, like we spoke about, babies are resilient and they will do what they need to do to adapt. And they'll engage bigger muscles to do that. They'll engage the wrong muscles. And parents want their child to succeed. So they will buy every feeding system under the sun to make that happen. And they just don't have someone to tell them that it could be easier. Especially for our first time parents, if you've never fed an infant before, you have no experience to lean back on to know, is this normal behavior or abnormal behavior? You're not sleeping. You're purchasing things on Amazon at 2 o'clock in the morning because that's what you need to do. They just don't know what's normal and what's not. And then we spoke about the fourth one would be just visual inspections are not enough. I'll frequently get referrals from families where the pediatrician has said, well, the infant can move their tongue. Obviously, there's not a tie. And that information is really harmful because they might not be able to move it because they might be able to move it a little bit. Like if it's a mid-tongue restriction, they might be able to get some side-to-side movement, some extension, but it's the elevation that they're really going to struggle with. So just looking at how a tongue looks will not give you the answer. All right, Andre. So we spoke about it before. An oral tie in infancy, it's not just about feeding, but it's our first entry point into helping this infant. What I always tell parents, they ask me, what if we don't get this oral tie fixed? My first statement is always, I don't tell parents about what could happen because your baby isn't there yet. We will only fix an infant tie if it's causing a problem in infancy. If it truly is not causing any problems with feedings or infant issues, then let's wait till the infant is 4 or 5 and they can be part of their healthcare. But an untreated tie long term can affect sleep quality because if your tongue is not resting at your palate, your mouth is not going to be sealed and you won't be nasal breathing. So you'll be mouth breathing at night. You really do need your tongue to be able to place to certain areas to make certain speech sounds, and articulating issues can happen if that's not the case. Now, some kids can have oral ties and not have speech issues, and some kids have speech issues without oral ties. So it's not a one-to-one thing. The other thing I see a lot is a tie that doesn't get noticed or doesn't get treated. Then the infant becomes 6, 8 months and they're exploring solids, and the family will tell us they're a really picky eater. They only like squishy things. And we always have to unravel that one a little bit because oftentimes it's not that the infant is a picky eater, it's because that infant is so smart, they've self-selected for the easier foods. So it's really hard if you have a tongue tie to eat a fresh strawberry or a crunchy piece of carrot because you have to chew on one side, use your tongue to move it over, chew again, use your tongue to get the food in the back. And if you can't control your tongue with that coordination, you're going to give up after a few tries. And these are the kiddos that might start liking pouches. We know that orthodontic problems can happen with crowded teeth and narrow archways, and I'm so excited that that information is becoming more generalized and more accessible for the average family, but it's still not something that everybody knows, and it's still not something that every dentist treats. So if we can prevent those orthodontic problems from happening, if we can help that infant grow into a child that doesn't have any mid-face restrictions of the maxilla or have any ear issues with their airway or with swallowing reflexes, that is ideal. And then, of course, there's some really big, great meta-analyses that are coming out with ADHD and its component to sleep disordered breathing. And there's a high correlation that if a child has ADHD, they are very likely to also have sleep disordered breathing. And we know that an oral tie, again, if you can't reach your tongue to your palate, can disturb your breathing. So if you are a parent that's watching this, if you are a birth professional, a fantastic pediatric therapist, then what I would recommend if you do suspect a tie in your child or in your patient is to really get them through a functional oral assessment by a trained provider. And that is not always the dentist. That's going to a lot of times be the speech pathologist, the occupational therapist, the physical therapist. They're going to be able to spend so much time with your infant to really know the limitations and the struggles that that infant might have. I really will also encourage all families, regardless if you're feeding with a bottle or at breast, to work with an IBCLC to help support that early oral function, especially in the first few weeks of that baby's life. And then if you have a tie that's confirmed and it's affecting function, then let's talk about doing a release. In our office, I only treat with the laser. This is something that we're going to do in a very evidence-based way. We're going to follow a protocol. We're not just going to snip the tie to see if it works. There's going to be a process. And that process very often is going to include some type of body work, is what a lot of people like to call it, but it's structural support. It's going to include craniosacral therapy, physical therapy, occupational therapy, maybe a chiropractic, whatever this family already has on their team, whatever this family would need. And then most importantly, we're going to follow up a frenectomy with post-operative care. So I can fix the anatomy, but if we don't work on the coordination of the oral tissues and structures, the infant is not going to have much, if any, improvement. They're going to have reattachment, so we're just going to go back to where we started. We need to do things differently so that this child can learn how to get coordinated with their tongue and then to get strength with it. So we definitely need to do the appropriate follow-up stretches for typically a month after we do a frenectomy. And this is going to help really restore that optimal healing and that optimal range. So one of my biggest key pieces is if you're a parent or if you are advocating for this parent as their therapist or doula or grandparent, really, really make sure that the follow-up care for that provider is discussed and followed. So how we can help at Latch Beginnings. So if you're in Austin or in Texas, we have a lot of families that travel from Corpus, from Houston, around the Victoria area. And then we have a lot of families over from Waco and Temple. So we're not just in Austin, but you're welcome to come through. We help by completing oral assessments of the tongue, lip, and buccal ties. I'm not just going to look under your kid's tongue and ask you a few questions. We're going to have a one-on-one. It typically lasts close to an hour. We're going to ask all the questions that you think are unrelated, but really they're giving me small tidbits of information that tell me the whole story. And if it's time to do an oral release, we're going to use a CO2 laser. It doesn't have any heat. It doesn't have any water. We don't want to introduce either of those things to a really small infant's mouth. And this will help with being really effective at healing and just having as minimally invasive a procedure as possible while still getting all those posterior fibers. So we're not using scissors just to clip the little itty piece at the beginning. We're doing a full functional release so that we can make sure that we are getting this child on a better trajectory. At Latched, I might spend too much time with my patients if you ask some of my team members. I really believe on one-on-one support. So all infants will see me, and that's an important part, both as me as a doctor, but as me as a parent. I want every family to feel really empowered so that they know they're making the right decision, but that they're prepared for the follow-up plan so that after we do the release, we know how to follow through with that to get the child the best information. And sometimes that's emotional. So sometimes what we provide is emotional support and a lot of education so that we can get the family where they need to be it with me or be with a different provider or a different therapist. And I always tell families at Latched Beginnings, the way that I like to practice is I do not want to practice in a way that just offers a quick fix. We're really intentional about the long-term care of getting this child maybe not to the end of their journey, but on a much better trajectory so that they have a pathway to getting back to healthy. And I always like the parent stories. I won't read these because you can read them, but I always tell families, if I could judge my happiness on how many thigh rolls these babies have following a release, it would make me so happy. And it's just nice to see families that we do a release and the week later they come back and the parents look happier. They oftentimes have had a shower when they didn't the time before because they were so exhausted. And you can tell they might not be at the end, but they are at such a better place that parenting is starting to become joyful instead of this, journey that they don't understand. And that makes me really proud. It's definitely a passion project that I've chosen as my profession. So again, if you feel like something's going on and an oral tie might be part of it, your next steps would be you can schedule an appointment at Latched Beginnings and you can visit our website and there's a lot of resources. We've updated the whole thing, so I hope you like it. And there they'll have lots of different information. You could schedule an appointment. And then we always like our team. We love Instagram because it's such a wonderful resource in the right ways for our parents, especially when you're up by yourself feeding your infant at 3 o'clock in the morning. It's nice to be able to look at something, tips and tricks. So follow us on Latch Beginnings on Instagram. All right. Let's see. Did anybody have any questions? Well, I love that. Thanks for joining, Hannah from Alaska. I love that. And you're a mom of two. Any questions? If you have any, feel free to answer them now, or you can send them through our email, and I'm happy to answer them that way.
Yeah. One thing I would also love to know, I would love to know what impacted you guys from this. Obviously, coming from a sense of a provider, or maybe you have some form of relation to it. I would love to know if there's something that impacted you guys from the webinar, maybe something that stood out to you that you didn't know in the past. Like something for me that I thought was super interesting was that um, how smart newborns are, how smart babies are. Dr. Collado was mentioning that when they have pain or when they're trying to eat, they're going to do whatever they can to be able to eat and eat appropriately. Which for me, when I think of a baby, I'm like, wow, that's ingenious, and how beautiful the human body is to be able to go through that. So that's something cool that I learned today. I would love to know what everyone else learned. If you guys want to share a quick sentence or a little thing snippet, it would be really cool to see.
Yeah, I always like to tell parents their babies are so smart. They're
Yeah,
babies, they can't speak, but they're telling you what they need, which
yeah.
sometimes it's hard to understand though. Katrina, do I treat children beyond infancy? It's a good question. Yes, with some modifiers. I have a lot of families that will see that we're treating the second or third kid as an infant because feeding problems have existed for the older kids and the parents didn't know about oral ties. And that's when we're realizing, oh, big sister has an oral tie or big brother. Once children get past the age of about 10 months, it becomes a little more challenging because now we've had teeth that have developed, their arch, which is the spacing around their mouth, has developed. So the answer is we don't treat them, but the treatment plan will look much different. We'll probably add in some physical myofunctional speech support along the way, and it will probably be several months before we get to the point of releasing them. So sometimes is the my biggest answer, but reach out. We can always help with specifics. Yeah, Hannah, I agree. It's impactful that sometimes are visible and sometimes they're not. And if you're just looking for what is visible, you're going to miss a lot of it. And can you briefly describe, the question is, can you briefly describe what a healthcare provider who might screen for ties would see anatomically with a buccal tie? Ooh, that's a good question. So buccal ties are in your cheeks. If you pull, you're going to do this at home. So when you go to the mirror, when you pull your cheek out, it's right around your premolar and molar where you'll see that tie. A good reference point is it's usually at the edge of your eye. Buccal ties are going to present a lot differently in that there's not as much movement going on in that area as you would on the lip or the tongue when you're feeding. So externally, you're probably not going to see anything. When I'm evaluating if I treat a buccal tie or not, I'm accessing inside the mouth. I'm feeling for symmetry. I'm looking at, do they have a head tilt? Has their physical therapist talked about torticollis to one side? Do they have, trunk or hip asymmetry to one side that's being adjusted by the cranial sacral therapist or the OT? If the tension pattern is the same, sometimes it's not the buccal frenulum that's tight, it's just that whole muscle is tight and it's not moving. Sometimes it's both. So externally, you're not going to see anything, but really feeling inside the mouth, feeling the different structures for symmetry and range of motion would be my biggest takeaways. All right, guys. Thanks so much for stopping by. Again, if you have any questions, reach out. I hope you have a great day. Bye.
Everyone.